Elizabeth asked me to share a little bit about what inspired my journey to become motivated to be curious about caring for patients with behavioral health concerns, and specifically patients at risk of self-harm. And one of the early formative experiences I had on this journey was a patient I cared for as a third-year medical student. I had the opportunity to be involved in the care of a young man who had sustained really serious physical injuries in a self-harm event. And I cared for him over the course of both my surgery rotation as a medical student and then my psychiatry rotation back to back. And so I had the opportunity to get to know him over the course of about 18 weeks, which was just, a really kind of a lucky thing that I had in my training. And I had the opportunity to see him go from somebody who was really at one of his worst moments, where he was very seriously mentally ill and physically ill, to a point where, later down the road, he, had began to recover some of his love of life. And I got the chance to talk with him about the sports that he loved, about the books that he was reading, about the plans that he had for his future outside of the hospital. And one of the things that was really formative about that experience for me is that until then in my medical training, we had focused on things like pharmacology, pathophysiology, microbiology, things that really helped me understand his physical injury and how to care for them. But not a lot that helped me understand the factors that led him to injure himself and what was going to be really important for his path forward. And so through that time, I got to know lots of experienced clinicians who knew much more than me and kind of opened my eyes to different types of thinking. So thinking about things like trauma, isolation, how those things affect neurobiology and family dynamics, and really motivated me to be curious to learn more about those kinds of topics. And so through the care of that young man and then the many other kids that I've cared for who have had similar and different types of presentations of self-harm, I noticed that the approaches were so different depending on where I was working at the time, whether I was in more of a capacity as a medical clinician or working more alongside behavioral health clinicians, whether it was an inpatient setting or an outpatient setting, that I saw millions of different ways of approaching this patient population. And as I finished my clinical training, and I started thinking about what I wanted to focus on in my career, I got really curious about, how can we kind of streamline all of these things? Maybe there are some common themes to the approaches that we're taking that are more beneficial for patients than others, and how can we figure out what those common themes are? And so that kind of line of thinking led me to be interested in mental health services research. And so as many of you know, in addition to my clinical work, one of the things that I do is mental health services research focused on understanding how to best integrate mental health care into hospital and emergency care for kids. A recent research study that I've been involved in that actually a handful of you may also have been involved in, where Diana and Cadence in the back there, and I talked with clinicians, with patients, and with the parents of patients who were hospitalized for either a self-harm episode or an episode where they were having thoughts of self-harm. And we learned so much from everyone we talked to, and I'd like to share a little bit about what we learned, and hopefully when I'm done here, you can tell me your reactions on whether that feels on base or off base. So I'll start by talking about some of the things that we heard from clinicians. I think an overwhelming theme that we heard from clinicians was a sense of both, feeling there are many rewards to caring for patients with behavioral health concerns, but also some common frustrations that make the job in the hospital of caring for this patient population really difficult. The first thing that we heard is that people worried about risk of injury to themselves and to their colleagues. And we even had a couple of clinicians specifically tell us that, even outside the workday, they would take some of this home with them. They would be hyper vigilant after work, and be thinking about, an event or an encounter that they had with a patient even after the workday was over. Alongside that concern, we also had people tell us that they were worried about their own clinical skill set. They said, I'm trained in how to do this maybe in a certain type of setting, or maybe I don't have the training to do what this family needs. They wondered whether the approaches that they were taking were really in the best interest of the family. And so a lot of kind of questioning and self-doubt about folks' clinical skill sets. And then the third theme that we heard in terms of frustrations about caring for this patient population were time and energy and resource concerns. So folks would tell us, I don't know, with all of my busy responsibilities, I don't know that I have the time and the energy to do what it is that this patient and family needs. We, Cadence and Diana and I, and other colleagues that I've kind of reflected this information to, that really resonated with me. I've certainly felt every single one of those things. I've worried about myself getting hurt. I've worried a lot about being part of a team where a lot of people are getting hurt. I've worried about, I go into a room and do I really know the right thing to say in this situation? Do I have the right training for this? And I've certainly had the experience of, I'm not sure I can go into that room right now because it's going to be 30 minutes before I come out, and I have 5 other things I need to do and other patients who also need me. And it's going to be really a tough thing to strike a balance between the needs of everyone. To share a really difficult case where kind of all of those things were involved, that was kind of another formative experience for me. I cared for a young man who had autism and serious self-injury and also injury to staff and others. And we were struggling to find the right combination of medications and behavioral approaches that were going to work to help keep him and everyone around him safe. And so every day it was my job to have one-on-one sit down with his mom and to tell her, here's what we're trying and here's how it's going and here's what we're going to do next. And we weren't making really the kind of progress that everyone had been hoping for. And that nobody was nobody was doing well with the situation. It was hard on the staff, it was hard on the child, it was hard on the mom. And that was hard for me. I felt a lot of kind of shame about my own skills, like why wasn't I better at this? Like, should I have studied harder, or done a different rotation in medical school? I blamed myself. I thought, if I were a better attending, then my team would be better, and then this child would be getting better faster. I worried about getting injured and my teammates getting injured. And so I feel actually a little bit lucky to have had that experience so early on in my journey as an attending, because it forced me very early on to kind of identify those things, to check myself, and to recognize, okay, I need better strategies to think about how to take care of myself and how to implement some coping skills. And so 3 things that worked well for me in that patient case, and where I'm not there yet, but I think I'm getting better at doing some of these things as I grow. I find that for me, it's really important to stay engaged in my activities outside of work. So, it's simple stuff for me, getting home in time to cook dinner and play with my dogs and spend time with my husband and read a book, that does it. That is what I need to strike a balance and to keep my mind engaged in something else, so that I'm not ruminating and thinking about what could I have done differently, and how could I have prevented something from happening. So that's the first thing. The second thing is conversations with colleagues. So when I was in that tough situation where I was getting a lot of blowback about a tough situation, I was kind of taking it all onto myself. And once I started talking to colleagues and saying, this is what's going on, how does this feel to you? It helped me see the situation from all sides, and it helped me feel like, wow, are there a whole lot of factors that are playing into why this is going the way it is? And most of them don't have anything to do with me or really with anybody. It's just the state of the state. And so I find that that's enormously helpful, and that's something we've actually integrated into some of the care models. For example, the MBU, it's something we try really hard to do, is to build in these times when colleagues can have conversations with each other, just to kind of take a step back to get a full perspective of what's really going on. And then the third thing is, after that patient case, I had the opportunity to do some debriefings. So formal debriefings both within my own division, but then also with the quality improvement group here at the hospital. And some of the work that came out of that patient case laid the foundation for, many years down the road now, for what you guys are doing here today. And I have to say that since I started here in 2014, I've seen so much enormous progress in what we've been able to do for patients with self-harm and behavioral health concerns. And I think, this group here is so well poised now to take some of those successes and really to take it to the next level. And so when I think about quality improvement for kids with behavioral health concerns, I think one thing that can be challenging is it's not always clear that there's a specific evidence-based way or scientific approach to exactly how we should do things. But I do think that we do know a lot of what can work from our own experiences. And I'd like to share a little bit about what patients and families have told us has worked for them, just to help motivate you guys, and hopefully this will resonate with some of your own experiences. And the way actually Catherine helped me to think about it was, maybe there's not just one approach going forward, but we're all here to kind of develop a process together. And so in the conversations that Diana and Cadence and our team has had with the patients and families who are here for self-harm or for thoughts of self-harm, we heard a couple of really key themes that really informed how I practice, and I think made me a more confident clinician in the things that I do know that I know how to do well. And so the first thing that parents often shared with us was their sense of relief and their sense of gratitude that we were able to provide a safe environment for their children. In particular, there was one mom who told us, the moment when she was admitted to the EDECU and she met the nurse and the psych tech, and she knew that somebody else was going to have eyes on her child and give her a chance to step away from the bedside, that was such a huge relief. So she could go, she could make a phone call, she could take care of her other children's needs without having to worry that in her absence something devastating was going to happen to her child. From kids and teens, we heard a lot about how much, particular things that they liked about their interactions with staff. They told us that having nurses and psych techs and other clinicians who just listened to them was enormously valuable. They particularly liked it when clinicians had taken a little bit of time to know what the chart said so that they didn't have to rehash their whole entire history of every interaction they ever had with a behavioral health encounter, and specifically the events leading up to their hospitalization often felt difficult for them to talk about, so they liked it when people were already informed about what had happened, and they could kind of start with that forward-thinking approach. And then lastly, both parents and kids, when we asked them specifically the question of what has gone well during your hospitalization at CHOP, they said, our communication with clinicians. We feel like the compassion that we're feeling, the smiles on everyone's faces, the fact that we're being treated with respect, all of that has made this a really positive experience for us. And so, hearing those findings, and when I now take care of patients who are hospitalized for self-harm or risk of self-harm, I pull from my skill set as a general clinician. So I think about, okay, this is a family that's experiencing a crisis, just like a family of, a baby with bronchiolitis, which is, bread and butter in general pediatrics. They're stressed, and I just pull on that same skill set of things that I know how to do in terms of being a good listener, caring for them with compassion, making the hospital a comfortable environment, whether that's telling them about the Connolly Center or the Wawa card, or remembering to use the right nickname that might not be documented in the chart yet, but that the child prefers to be called. Those kinds of things really make all the difference.